Hi everyone, welcome to another USMLE case presentation on the cardiovascular system. Today we'll be looking at a case in pathology. I'm Dr. Wahid Mahabir and you could use this video to aid in preparation of your USMLE exams. Alright, let's look at the vignette. 74-year-old male patient presents to the emergency with complaining of worsening shortness of breath and fluttering in his chest for the past 24 hours. He has a significant past medical history of severe COPD and uses home oxygen at 2 liters per minute. On physical examination, he appears anxious and is using accessory muscles to breathe. His blood pressure is 138/88, heart rate 114, respiratory rate 26 per minute, and saturating 97% on 2 liters. Auscultation reveals diffuse expiratory wheezing and decreased breath sounds bilaterally. Cardiac auscultation demonstrates an irregular rhythm with a tachycardia. An EKG is obtained and shown here. So have a look at the EKG. Some hints are provided also. And the question is, which of the following echocardiographic features is required to confirm the most likely diagnosis in this patient? A sawtooth pattern of atrial activity, an irregular rhythm with absent P waves, at least three distinct P wave morphologies in a single lead, D a prolonged PR interval greater than 200 milliseconds with drop beats, and E a short PR interval with a delta wave. So feel free to pause the video at this point and you could lock in your answer. The correct answer is C, at least three different P-wave morphologies in a single lead. So if you go back to that slide, you would notice that there were three distinct P-wave morphologies in the single lead. Similar EKG is shown here too, demonstrating multifocal atrial tachycardia. You can see three different P-wave morphologies here. For example, this is one type of P wave, another type P wave looking different, P waves here also looking different, um, another distinct type of P wave here also. So this is what multifocal atrial tachycardia looks like. Some other explanation of why that's the answer. So this is usually a important diagnosis and is really highly associated with pulmonary disease. And some other clues in the vignette that we had. This patient had COPD and also hypoxia and wheezing, and that could precipitate this irregular rhythm. The physical examination in the patient noted the patient had an irregular rhythm, and you would know that this rhythm is very commonly associated with atrial fibrillation, and that could lead students to pick the incorrect answer of atrial fibrillation. But if you looked at that EKG in the vignette, it's not vibratory wave you're seeing. There were P waves. So once there's P waves in the EKG, it's not atrial fibrillation. So this slide is just reiterating what I was saying. Multifocal atrial tachycardia is caused by multiple atopic foci within the atria, firing chaotic impulses. That's why every P wave looks different because it's coming from a different part in the atria. Rhythm is irregular. The two most common rhythm which produce the irregular rhythm and pulse would be atrial fibrillation and multifocal atrial tachycardia. Alright, so A is incorrect. A is a sawtooth pattern, which is atrial flutter. In our patient's EKG, we did not see a sawtooth pattern, so it's unlikely to be atrial flutter. B, absent P waves. This is atrial fibrillation. because we saw P waves in our uh, EKG, is likely not atrial fibrillation. If P waves were absent, then it could have been atrial fibrillation with an irregular rhythm also. Alright, a prolonged PR interval. This would indicate AV block, likely Mobitz type 1. Um, while blocks could be irregular, the primary issue here is supraventricular tachycardia, not a conduction block. And E, a delta wave, is associated with a Wolff-Parkinson-White syndrome. Um, this, we did not see a delta wave in our EKG, so is unlikely to be a reentrant tachycardia. Alright, so reviewing some high-yield learning points for this case. Predisposing factors to multifocal atrial tachycardia. We have lung disease. This is CSPD exacerbation is the number one cause from the atrial stretch, and hypoxia that's present which could precipitate this type of arrhythmia. Also, metabolic issues like hypokalemia, hypomagnesemia, those electrolyte imbalances. Drugs such as theophylline toxicity could precipitate multifocal atrial tachycardia also, and too much uh, albuterol use. Sometimes patients would present with symptoms of their underlying lung disease, like patients with COPD, they would present with shortness of breath, wheezing, rather than palpitations. In uh, patients with multifocal atrial tachycardia, and the pulse would feel just like atrial fibrillation. That is, it's irregularly irregular. So how would we go about managing MAT? Is not a shockable rhythm. Um, Cardioversion is ineffective. How we would treat it is we treat the lungs, we treat the underlying cause that precipitate the multifocal atrial tachycardia and try to correct it. So, for example, we treated COPD exacerbation with giving oxygen, giving bronchodilators, for example, and rate control. If needed, we could give calcium channel blockers like verapamil, diltiazem. These are preferred because beta blockers are usually avoided in patients with underlying lung diseases like COPD to prevent um, bronchospastic disease. All right, thank you for looking at this video. If you like this video, give me a thumbs up. If you want to see more content like this, subscribe to my channel, and I'll see you in the next video. Bye.